כעת נעבור למושב שיעסוק בנושא הקורונה. אמנם מגפת הקורונה מאחורינו, אבל אנחנו רוצים לעסוק בשאלה האם הקורונה... תודה על העזרה. כן, אז אנחנו רוצים לעסוק בשאלה, למרות שהקורונה די מאחורינו, ואתם בטח שואלים את עצמכם מה קשור עכשיו הנושא הזה, אבל הוא מאוד מאוד קשור, ואנחנו רוצים לעסוק בשאלה האם הקורונה הכינה אותנו למגפה הבאה, שאנחנו מאוד מקווים שלא תבוא, אבל אנחנו חייבים להיות ערוכים לכל סצנריו. אז for this session, I'm honored to invite the first speaker to the stage, Professor Mark Dibble, who is Chief Strategy Officer at the Center for Global Health Practice and Impact at Georgetown University. וכעת אני מתכבדת להזמין את פרופסור גילי רגב יוחאי, שהיא מנהלת היחידה למניעת ובקרת זיהומים ומנהלת מכון שיבא למוכנות למגפות במרכז הרפואי שיבא תל השומר. תמיד יש להם טייטלים מאוד מאוד ארוכים, אז והמושב הוא בהשתתפות ובהנחיית פרופסור ג'וני גרשוני, פרופסור לווירולוגיה ואימונולוגיה באוניברסיטת תל אביב. אבל רגע לפני שנתחיל במושב, 30 שניות מעברון. אתה יכול לשבת? 30 שניות מעברון.
I assume we can start. So just give me the 30 minutes on the clock. So, first of all, welcome. We'll be conducting the discussion in English. December 2019, the Chinese reported a cluster of severe pneumonia in Wuhan. By the end of February, there were over 80,000 cases reported, and on March 11th, 2020, the World Health Organization, the WHO, declared a global pandemic. Now, initially we were optimistic, and we assumed that coronavirus, SARS coronavirus 2, the cause of COVID-19, would peter out in the summer, as did SARS coronavirus 1. However, unfortunately, we've been coping with a massive natural disaster for the course of the last 3 years. But if I look around in the room, social distancing in the previous lecture was not a problem. Nobody's wearing a mask. And for the most part, Corona seems to have passed. Can you give me some perspectives as to where has the coronavirus pandemic disappeared? Gilly, please.
Yeah, so in short, I'll say that the virus is not gone, okay? And I don't think it has weakened. I don't know what Mark thinks about that. And I think really the role of the place where we are, which I call it the post-pandemic phase, is due to vaccination and what we can call maybe partial herd immunity. But let me go back to January 2020 and maybe explain why, in a way, that was obvious then. And I actually was one of those, and I know many more, who thought it's not just going to go away. It's not like SARS-1. And the point where I understood that was when I heard about the German conference where it was very obvious that there was asymptomatic people who are infective. And once they are infecting others and we can't detect them, we can't just tell them, like in SARS-1, stay at home or be isolated, quarantined. We can't do that because we don't know who they are. This is going to spread and we're going to have a pandemic. And in order to stop that, we have to have some kind of preventive measures like vaccines. And if we don't have that, it's just going to continue and spread. I didn't know how severe it's going to be, if we'll have 1% mortality or 20% mortality. That was very frightening in those days. But I think that was really one of the points. And if, to come back of where we are now in the current stage, I think that, again, COVID is still circulating. We're seeing it. Whether it's going to be some kind of another seasonal coronavirus, very mild, milder than flu, I don't know. That's optimistic. We are seeing emerging variants ongoing. We don't know what the next variant is going to be. I think we need to be prepared for the worst, but hope for the best.
We'll deal with preparedness in a moment. Mark, why don't you give us some of your perspective?
Just very quickly, building on what Julie said, you know, I think it's been said and is true. We're done with the virus. It's not done with us. We're tired. We don't want to deal with it, but it's still there. As of March of this year, it was the 4th leading cause of death in the United States. 4th leading cause of death in the United States. It is very much still here. For the future, we don't know where it's going. Like many viruses, I would just give 2 cautionary notes. Coronaviruses are very different than other viruses, and people have not paid enough attention to that. We have known for years, coronaviruses cause about 1/3 of common colds. So we haven't studied them a lot because they haven't killed a lot of people until SARS-CoV-2 and SARS-CoV-1 and MERS before. What we do know about coronaviruses is that you can be infected with the exact same genetic strain a year apart and get just as sick. So we have known that our immunity does not last, which is why we've been getting all these boosters. And so we don't know what we're ready for or not ready for, which makes herd immunity a little more difficult. The second is variants, as Julie mentioned, and we don't, influenza, we're watching right now a variant. Like that, we will see variants. And whether it's next year, in 5 years, in 10 years, will we see a 20% fatality rate coronavirus, SARS-CoV-2? We have no idea.
Let me, in that case, mention that the caution that was mentioned in the introduction, are we prepared for the next emerging pandemic? Spoiler, yes, there are going to be emerging pandemics, they're going to see them. And so, Mark, maybe you can give us, due to a global perspective, what have we learned about COVID-19? What lessons indicate that the pandemic was handled well, as opposed to where were the errors, and some thoughts about preparedness?
So I hate to be a big spoiler, but I think we're in worse shape now than we were 2.5 years ago.
That's enough.
Yeah?
Yeah, okay.
And we will not fight a new pandemic well at all. It'll be a repeat of what happened last time. What we did well is not much. A couple of countries did well. These are countries that had SARS-1 and had existing systems. So they moved and did contact tracing and social distancing and very quickly and had very few cases. I'll come back to what happened to them later in the pandemic. The second thing we did well is the research community came together rapidly and worked collaboratively globally. And that led to pretty rapid advance, including the vaccine. However, that vaccine was built on 15 years of investments in mRNA technology, which had largely failed for everything else. And it was built on an accident that 2 researchers from NIH had stabilized the spike protein, which was essential to create effective vaccines. Effectively, things that happened for 15 years for other purposes. Now we're working on potential platform technologies, but we're not there yet. And so while we did well on the collaborative research before and some countries did well, they're both very indicative of what we did wrong. So the biggest thing we did wrong is had no humility in the face of a pandemic. at least public-facing humility in the face of something we really didn't understand. In terms of the countries that did well, they got very complacent. And when Omicron came along, they did very poorly because they had stopped the contact tracing, they'd stopped their social distancing, and they didn't buy any vaccines. And no one was vaccinated. And so they got hit pretty hard. So what looked good at the beginning, lack of humility, they thought they were done, they thought they were fine, and then they did just as badly as everyone else later on. On the vaccine front, the humility piece has not played out at all. We do not have good technology for future pandemics, and we are way too vaccine dependent. So by the time you get a vaccine produced, you already have a pandemic. We've barely focused on treatment. We have terrible treatments for this pandemic, and we don't have very good antiviral treatments at all. If you had good antivirals, you could battle almost any virus, keep it down low so that you prevent it from becoming a pandemic so that you can develop a vaccine. We've done very poorly on that. The other thing we did extraordinarily poorly on is communications, and that was lack of humility. Instead of saying, this is what we know now, we don't know, it might have a lot of asymptomatic transmission. Many of us said this, not many, but enough of us. We didn't say, this is what we know today. It could change tomorrow because we don't understand where this virus is going. So we make these recommendations today, like masking, like social distancing, like closing schools, like shutting down airports and shutting down communities. But we knew by June, July, you didn't need to close elementary schools. Yet we kept, at least in the United States, them closed. So now there's a massive backlash because we didn't communicate, and now people look back and say, well, you didn't need to close those schools, and you did. Why do I trust you? You told us masks work. The global data show they don't. Well, they do work on an individual basis. They don't work on a collective basis. And if you're compromise, you need one. But we weren't nuanced in our communication. And now, because of that, going into the next pandemic, no one trusts us. So that's a problem.
Then shift to Gili and say, are we doing anything to prepare ourselves based on the lessons and for the future?
Yeah, so again, maybe I'll start with what we have learned in Israel, and specifically through some of the work that we've been doing at Sheba. And we, very early in the pandemic, established what we call the Sheba Healthcare Worker Cohort. And what we did was recruit any healthcare worker who agreed to donate blood on a monthly basis, and we followed their immune response to infections, to the vaccines once it was there. We understood very early that we need real-world evidence on how the vaccine effectiveness, on correlates of protection, all of that. And actually, we learned a lot from that. We have many, many outcomes that not just Israel, but the world learned from that. Among them was the decision to give a third dose. This is the only or the first time, and I think the only time, that Israel decided to give a medicine before FDA approval. And that was based on some of these studies. So, and then on the other hand, we learned after the fourth dose that it's maybe necessary only for immune suppressed and not for everybody. Or it may help slightly, but don't have high expectations. And I think all of this that we've learned actually brought us to a lot of international collaborations. Among them, most importantly, is the collaboration with the NIH. And with that, we now established what we call SPRI, which
This is at Sheba.
This is at Sheba. It's the Sheba Pandemic Preparedness Research Institute. And we are looking forward into how can we learn, one, from this cohort, but maybe later I'll mention other cohorts that we're now building. One is through a lot of novel technologies that have been developed at the NIH by Professor Danny Dueck. And we've trained part of our team already there, and they're coming over here. And we now have these techniques to actually develop monoclonal antibodies, which can be given as a treatment, and they're also passive immunization to various pathogens. Right now, we're still looking mainly at COVID, And that's one of the things we're doing. Another thing we're doing is looking at, together with a pharmaceutical company, looking at a pan-corona vaccine that we can hopefully develop. So these are the kind of things that we're looking for the future.
So this would be a pan-corona vaccine, meaning one vaccine that would be effective against even unanticipated as yet variants of concern, which is
Right,
of course...
and maybe against the SARS-1, maybe against MERS as well, yeah.
Yeah. Now, Mark, you said that, not to quote you, but that the job done in generating effective drugs was pretty miserable. Are there any technologies, new approaches, advancements that you can say might be useful to implement in order to try to anticipate not only variations in COVID, but new pathogens, other viruses, other diseases?
There is fortunately technology, and we hope it'll be a solution. By the way, you're very fortunate you're working with Danny Duick. He started NIH a couple years after me. I was in Tony Fauci's lab. He was in another. We collaborated a lot, so Danny's the best. It's been talked about a lot at this conference: artificial intelligence, large language models, machine learning is extraordinarily optimistic for the future and what it could do. So we can, with machine learning, with large language models, we can predict variants in viruses. We can predict from zoonotic, we trace what's happening in animals, and we can predict what genetic jumps are necessary to get into humans. We're tracking a couple right now that look pretty scary. And this is going to happen more and more because of climate change, because we're encroaching on our environment and getting closer to animals, particularly in low and middle income countries. And there's a lot of exposure without poor nutrition, a lot of other things. But you can predict all of that with artificial intelligence, large language models. And we are very hopeful and think we can do a lot with that. There is, however, a risk with that. And I think some of the conversation here, most of the risk so far is focused on social media, democracy. There's a real risk in biosecurity. And I'm actually going from here to chair a Bellagio conference with the top people from the White House and the 10 Downing and the European Commission on biosecurity in the age of artificial intelligence. And you live in a bad neighborhood, as the chief of the general staff just kind of pointed out. So as we're developing things, as we're looking at what variation in a virus will make it more infectious, how would you respond to that or not? Good actors will be doing that to help. Bad actors could be doing that for very bad reasons. And I've heard very senior U.S. defense officials worried that Russia could be doing some bad things in Ukraine with effectively tactical nukes, but with bioweapons. Other neighbors of yours have used bioweapons in the recent decade. And we are not far from someone in their garage, because of AI, if it's too accessible and if sequences are available in too accessible a way, being able to design the next pandemic virus that could wipe out the world and be 20 to 50% deadly, not 1% deadly. So how do you balance those two? And that's where there's the risk of bad things happening, but there's also the risk of us over-regulating and effectively unilaterally disarming while the bad actors are going. So where is the sweet spot between allowing the positives of AI while trying to limit and mitigate the downsides of AI? So it's a good, bad, and hopefully we'll err on the good side.
This seems to be the case for every new emerging technology, that it has wonderful, amazing potentials as well as very serious dangers. You know, you had mentioned, Gilly, that the new institute is trying to implement monoclonal antibodies. Monoclonal antibodies are the antibodies but target very specifically a given infectious disease or pathogen. Maybe you can help us better understand with some concrete examples.
Yeah, so but maybe just before I answer that, I'll go back to the AI
Please,
and where
please,
we're,
of
and
course.
then I'll connect to that. Because with the AI, what we're doing is, again, with the NIH and the pharmaceutical company, looking at, through the Sheba healthcare worker cohorts, we have both the data for each person, what kind of exposure he had, so whether he was infected with Delta or with Alpha or now with Omicron, which Omicron, whether he got vaccine, how many vaccine doses, all of that data, together with, from his blood, the blood samples that we have from these people, we know how well they neutralize each different variant.
So
And
the importance is through the insight that you had to generate the data set, which is
Exactly.
amazing.
Exactly. And with that, the idea is to build a new vaccine. So that's, and that's not necessarily going to be an mRNA vaccine. So that's one aspect of what we're doing. But if we're going to the monoclonal, which is what we're actually concentrating right now on, so one immediate thing is we already have a few discoveries of monoclonal antibodies from, again, these samples that are well neutralizing of the new emerging variants, the XBB of corona, which right now we don't have. So mainly monoclonal antibodies, I should say, right now serve the immunocompromised population. And they really don't have a solution. They're still, we are all, beyond this. We feel that COVID is over. They don't feel that way. And I see these patients in clinic. And they come and they say, what can we do? We're scared to go abroad. Because, for them it's still a big deal if they get, whether they get flu or whether they get COVID, which is worse. And for them right now, the solution is monoclonal antibodies. Vaccines are not as effective for them. And the monoclonal antibodies that we had up to recently, the Evusheld, before there was the Regeneron, they were they're not working on the new variant. So if we succeed to actually go and manufacture something like that, that might be
So that's
one
corona,
solution.
but can
That's
you
corona.
think in others
Yeah.
so people
So
can think a
we
little bit
have-
out of the
yeah,
box?
We have right now actually blood being transferred into Sheba from people who are going to the Hajj. Okay, so the Hajj is going to happen in a month. And the Hajj, like any very condensed place where a lot of people meet, very crowded, coming from all over the world, that's a very good opportunity for any virus, whether it's going to be COVID, whether it's going to be MERS, whether it's going to be a combination of these, whether it's going to be a new virus. So the idea is to collect blood before they go, after they return. We're going to collect all the data, whether something happened and people had any kind of new infections that we're not aware of. And if something happens, we have the blood from which now we've learned how to produce monoclonal antibodies against whatever will come up. So we're actually looking, forward before we even know what we're looking for. And that's one thing we're doing. Another thing is looking at something that we do know, the most, frightful pandemic that everybody was afraid of was the bird flu before COVID came up. And in Israel, actually, we had a very large outbreak of cranes. We had 8,000 cranes that, agurim in Hebrew, that died in the Achula. And a lot of people had to be exposed to take them out of the...
And their H5N1 flu
Right.
is the same that could infect and be very dangerous to us.
Exactly. We didn't have any human beings
Cases.
that were, any human cases, but these people were exposed and potentially maybe they developed antibodies and maybe that's why they didn't get infected. But if we can get those antibodies, develop monoclonal antibodies up front, if at some point we have a pandemic, we'll have something ready immediately and not have to wait for a year, or again, a year was very lucky, as you mentioned, it can take much longer. We'll have something prepared within weeks. That's the idea.
Mark, I'd like to ask you, you had mentioned the fact that the vaccine was the product of extraordinary work, Barney Graham and others at the NIH, in stabilizing the antigen, and of course, the messenger RNA technology, which is new, and yet, you also mentioned the fact that corona is a really nasty bug, and it doesn't seem to comply. People can get vaccinated, they are protected, but then they come infected again. What's going on with corona, and what would you say about future vaccines?
So we don't know, and because no one studied coronavirus in depth because there's no money in it because it caused common cold. So why would you spend a lot of money on something that causes common cold? we're starting to learn more, and I think we will learn a lot. Just like at the beginning, we knew nothing about HIV. We now understand the immune response because of the investments in HIV. My guess is that it is producing some substance that inhibits the immune response. But it's probably not the only virus that does that. So for example, we know that coronaviruses emit a substance that blocks interferon, which is a key part of our immune response. So does hepatitis B, so do other viruses. Measles. RSV. So there's the potential to start thinking about, well, are there not just coronavirus, but pan-viral antivirals, for example, interferon, that could be used in the early part of an outbreak of any viral infection, not necessarily to eliminate it, but to bring it down to a low enough level that by the time we have a vaccine, it's still an outbreak, not a pandemic. Because again, by the time you get to vaccines, you are in a pandemic state. So what can we do to bring that down? And what coronavirus is doing is very important. The other thing we should be doing, and we're not doing, is linking the worlds of oncology and infectious diseases. So cancers do a great job of emitting things over time and modifying themselves to protect the immune response from clearing the cancers. Viruses are like cancer. They live inside cells, which is why they're so difficult to get at. And so if we bring these worlds together, and again, artificial intelligence, large language model learning could help us do that, we could start identifying things that no matter what happens, we would be ready. But no one cares anymore. We say we should be doing. All the money for this stuff is dried up. People aren't investing in it anymore. Some drug companies are, but we're pretty much done with it. If we stuck with it and actually invested now, it could not just be for infectious diseases. It could not just be for pandemics. It could be for many infectious diseases. It could apply to cancer. It could apply to autoimmune diseases, many things. So that's the opportunity with artificial intelligence, using it properly to allow us to jump these different fields. But it's very optimistic if we invest and take the time to play with it.
I like the concept that it's very optimistic, and AI is being used, amongst others, to analyze the wonderful database that's been collected in Chiva. And so under these circumstances, I think it's a good place to stop the discussion. Thank you very much.